Okay, we will start the second presentation of today, and we will start sharing my screen. Uh, Hope it is obvious to you. Is that okay?
Yes, yes.
Okay. So my presentation today is that about the historical review of the changes in medical education. As Mumtaz preceded me in her presentation, as you noticed, the first session, the first thing in every session to be the objectives of that session. So what are the objectives of our session today? We means by the objectives is that what are the issues or things that we need the attendee to learn after the session that he wasn't being aware before the session. These are simply what we meant by learning objectives. The first learning objective in this presentation is that we have to state the stages through which medical education had developed, and this is very important. And Omnia, please admit all the audience who want to be admitted. So I am busy with the presentation. So we state the stages through which medical education had developed, indicating the main historical landmarks. And these are very important because we have to know how did medical education develop during the past centuries, and how do we reach to such a stage now. And the second learning objective is that talking about the Flexnerian system of medical education and what was its benefits and what is the criticism and shortcoming that have been recognized later on. And the third thing is that, which is very important for Iraqi medical schools, is that what is the importance of medical education unit to be established in each medical school, and what are the main functions or the duties of this medical education unit. Before that, I ask my question before doing this presentation. Why is this presentation? Why I want to present this now? And I will go back to another question, is that why it is important to study history and what we learned from history and how we are going to make use of what we have learned in our present and in the future. Uh, T.S. Eliot, in his Four Quarters, stated that time present and time past are both perhaps present in the time future, and the time future contained in the time past. And that's mean why we study history. The merits of studying the past is in order to understand the present and forge for the future. And this is very important part of the story that we have to learn. Medical education, there is continuing development at all levels and all the time. It's undergone and it is undergoing development all the time throughout the world. And this is very true when we recognize that kind of development. Overall, the development in medical education, either it is an overall approach or it is a detailed approach. The overall approach is that through the philosophy and the general ideas about medical education, and we can see the development of the curriculum from subject-based to problem-based. That is new changes in the philosophy of medical education. And also the new approaches is that the medical schools to be community-oriented medical schools rather than the past type of design of medical schools that is not very attached to the community needs and requirement. And the second thing is that these development might be at a smaller level or a more fine levels, which include changing the curriculum, modification of the curriculum, or teaching methods. And therefore, there are generally two approaches for modernization and development of medical education. One is overall philosophy, and the other was on a lower scale, addressing minor issues in curriculum. And the obvious thing in that, what is certain in that is that medical education development is a continuous process and happen at all levels. The change is inevitable because life is changing, we are changing, our needs are changing, and our community are changing, as well as the new challenges and threats. And if we take an example of the COVID-19 era, at the present time, these are new challenges, haven't been faced previously. Therefore, the medical educations and the curricula have to respond to that critical challenges and to be modified accordingly. I put these two photos from the ancient times where I don't know why barbers were the one who do surgical procedures and prescribing medicine and doing things like that. And this picture was by a barber surgeon in a busy shop in Paris. And the other photo on the right side is that it's showing a demonstration of anatomy, usually or take place in 1559. And you can see the type of demonstration to the learner. That was the beginning of training physicians and surgeons to do their job to help patients heal. Now, what makes medical education changed? There are two forces. The first one is external and the other one is internal. The external one, that is by policy and authority higher than the medical school, like in our country, the ministry or the university. It obliged the medical organization to restructure itself or to change its structure. So this is a force from outside, and we call it, or this is called a forced change. Then is another form of change come from inside, from the people working in curriculum development and curriculum implementation. When they reach a stage, they found that this curriculum is no longer appropriate or effective for the time being, so it must be changed. And this is called an elective change. So there are two kinds of change, that one is the external and one is the internal. There are usually some who benefits from the change and some who lose by it. And therefore, we can see that for every new ideas, for every new modification or a new philosophy, there are someone who are opposing that and standing against it. And I think all the countries or all the medical schools, the problem is the same. Now, prior to the 18th century, in Europe and America, the learned study of medicine and the preparation for practice as a physician was limited to a number of people of a certain social classes who have an access to a university study. The patient also came or landed from the same affluent classes. Medicine was studied in the university based on a classic of medicine and literature, and the main language of studying was the Latin language. That is the way by which physicians were created. It was different from the way of the other pathway for training the surgeons and the pharmacists and other healers. They were different in that issue. The movement toward practical training in medicine was mainly at the end of the 18th century. And there's a gaining momentum at a national level, international level. And here the national language have been used in learning medicine rather than the Latin language in these medical schools. And the medical practice itself have some sort of changes. Because of the different pathway of training physicians and surgeons and pharmacists, there is some way of drawing together these three lines to become one. And London wrote by 1830 the new idea of physician in Brighton, that is all rounded or a general practitioner. That is, he can diagnose, prescribe, and do minor procedures for the patient. And therefore, this is the first idea who came to have a general practitioner doing many items at the same time. By the end of the 19th century, the program study in medical schools was varied from country to country. But there are some similarities among these medical schools, and mainly the kind of medical training, including lectures and some demonstrations of the newer sciences, traditional classes in institutes of medicine, surgery, medical practice, pharmacy, therapeutics, and obstetric, and some provision for clinical or hospital instructions. You can see now the most of the training was not hospital-based or clinical-based. The early medical schools in America followed the European model. For example, the first medical schools in USA was launched in Philadelphia in 1765 and was modeled on the University of Edinburgh because the teachers were graduated from the Medical School of Edinburgh. And that was the students were admitted to the anatomical lectures and course on the theory and practice of physics. You can see the number of students sitting and observing and learning by observation only, while the teacher are in the middle demonstrating the anatomy for the learners. And however, by the end of the 19th century, many other had been set up for profit. There are some profit medical schools, and therefore the level and the quality was at question. And that was the trigger. That was the trigger for the recognition of the American medical education was, reorganization of the American medical education was initiated in several fronts because the quality was low at certain medical schools, and this triggered for the reorganization. And the first one who come for that was Abraham Flexner. Abraham Flexner was a headmaster of a secondary school. And Abraham Flexner was commissioned by Carnegie Foundation for the advancement of teaching. And he has an epic report that was published in 1910. He said about or talked about medical education in the United States and Canada. In this report, he pointed out many shortcomings of the American medical education system and called for a higher standard and a quality control. And he recommended the medical schools to be integral part of the university, faculty of the medical schools to be involved in original research, and students to become more actively involved in laboratory and real clinical experience. This system, which is advocated by Flexner in 1910, included separation of the medical school years into two parts. The first 1 to 2 years is that of the preclinical basic part, and another 2 to 3 years of clinical part. And this was an improvement over the past ad hoc system of rather unstructured apprenticeship. I will explain this in Arabic. الابرنتشيب تعني الصنعة، يعني كان اكو اسطى وصانع. الاسطى عند الخبرة يشتغل واحد جوا ايده يتعلم الصنعة منه. This is what is called by the apprenticeship. Many of the medical schools of the lower quality was not able to match the requirement by the Abraham Flexner, and therefore they were closed, while others who are able to match the Flexnerian approach, they continued. And that system, which is suggested by Flexner, continued for more than 100 years, for a century. And you can imagine at this point, because I will come to back to again. What about the issue in Asia? In Asia, because of the colonial powers brought medicine to Asia in the 19th century, many Asian medical schools following the same program of their colonial master. And therefore, medical schools in India, Pakistan, Bangladesh, Malaysia, Singapore, Iraq, and Australia were following the British system, while Indonesia following the French system. It depends who is the colonial master who carry the same curriculum of their medical school to their colonies. But these medical schools in Asia have in common certain problems, and we are still facing these problems till now in certain medical schools and in certain area. There are large number of intake of medical students. There are very large classes, large number of students. There is limited opportunities for the student to pursue an independent learning or to have an elective or to be an active part of the learning process, as well as the assessment system is antiquated and deficient in request for validity and reliability. And these difficulties are faced by many medical schools in the Asia region. Medical schools in many countries are still struggling to revitalize their medical curriculum and to be aligned with the new development in life and in the society needs. And this is a positive way that we feel that we need to change and to match what is going outside, to match the society need. By the end of the 20th century, the Flexnerian system have been developed worldwide. And even in Iraq, if we have around less than 30 medical schools, just 10 years ago, all the medical schools were following the Flexnerian system, while since 2011 or 12 till now, there are 10 medical schools modernize their curriculum into the new system-based or problem-based. The Flexnerian system established a standard in medical education with focus on quality control and served the medical schools for over a century, very long time. However, in recent years, there is a realization that we need to change from the past Flexnerian system. And there are many criticism and shortcomings of this Flexnerian system. The most important of which is that the separation between the clinical, preclinical, and the clinical years. And most of the preclinical years study will be lost during the clinical years. And even the student will be stunted. Why I study such and such and such if I am not going to use it in my future years or after graduation? And this is one of the main criticism is the separation between preclinical and clinical years. The second one is that because there is tremendous advances, because the medical schools become university-based, it must have a very active research part. And this research part goes for the discipline and specialties rather than for medical education. And this is one of the shortcomings of the Flexnerian system. The third thing is that once the research was focused on discipline, the content expanded of the curriculum became more specialized, and usually there is a mismatch between the profile of the doctor graduated from this medical school and the society needs. And we're all facing such a problem, because when I attached to Baghdad Medical Schools about 15 years ago, and I am cardiologist, I try to give all my cardiology information to my students, and therefore I try to improve my students in cardiology. And I don't know what are the sharp lines that separated the data should be given to the undergraduate from postgraduate. And this is a very important issue. I'll come to it later on. Other criticism to the Flexnerian system is that the medical school following in Asia, following the Western curriculum, there is disbalance between the biomedical theories and between the clinical skills. And unfortunately, many medical schools do not appear have a clear educational mission. I was elected as one of the members of the National Councils for Accreditation of Medical Schools. And we are now applying for WIFME for recognition. And we visited many medical schools. Some of them, there is no mission statement. And some of them have copied mission statement from elsewhere, and they didn't reflected in their program, in their assessment, in their monitoring and evaluation. And therefore, we found that some medical schools, or many, have no clear mission statements. The other issue is that we have to answer, every medical institution have to ask the following questions. What should be the primary focus of medical school be? What should the medical school graduated? Uh, Previously, I told you, I imagine the medical school as a factory, that it has certain product. What kind of a specification of that product? Should it be the need produced for the need of the patient, the society, or to focus on the scientific rigor of that graduate? Where should the training take place? At tertiary teaching hospitals, or at primary healthcare, or a mobile clinic? Do the medical schools want to train clinical practitioner, or they want to train a researcher, or both? These questions have to be asked and answered by each medical institution graduating medical students. What constitutes quality in medical education? So what is the quality of medical education? They are divided into two groups. The first group, who are believer that the quality of doctors should not be affected, or it would be jeopardized by the lack of the scientific rigor. Therefore, they have advocated strengthening of the basic sciences in the early preclinical years. And as long as there is advances in exponential advances in the biomedical knowledge, a great emphasis were put on the teachers as the expert who would transmit the information by didactic lectures, and that was the idea. And then the curricula was poorly coordinated, as individual basic science department start to teach as much as possible to the medical student without indicating the relevance of the science to the clinical practice. So the student will be learned so many issues in the basic years, but he couldn't realize what are the importance of these data to the future. And that was on one side. So we will end it by a lecture hall like that. Some of the students are sleepy at the end. The lecturer is talking too much. He is reading in the slides, as I'm doing now, and most of them are sleepy or not in eye contact with the teacher. But if we change it to real life now, we can see many students seated back, and they are playing with their mobile phones and probably playing games, while a boring lecturer like me is teaching and talking too much without attention to the student. On the other hand, there is other group who are believer that the medical education should serve the need of the community, and at the end, the benefit of the patient. There must be a great emphasis in the training of medical practitioner، مو بس المعلومات والنظري اللي يتعلمها والامتحان والدرجات. There must be increasing exposure to clinical training, including primary care, communication skills, medical ethics, preventive medicine, and health maintenance. This is a very important issue to be learned. Early clinical exposure to the medical students, and alhamdulillah, many medical schools now following the new integrated system from year one, early clinical exposure of the students, and they trained their part of their training is at the primary health care centers, and medical ethics becomes a module, essential module of the curriculum in many medical schools, as well as communication skills. So this is the second group from the other side. Now, these contradictions serve to emphasize that medical school decision makers have to have a clear idea about what kind of doctors they want to graduate. This is very important. Every medical school policymaker have to sit and think deeply about the mission statement and the specification of the graduate they want to deliver in the future. Now, About that, many recall for reforms comes from the international organization. One of them is the WHO, and the second one is the WEFME, World Federation for Medical Education, and others. They publicize the need to reform medical curriculum to fit the society in which the medical school is situated. The primary aim of the medical school is to graduate doctors serving the community in which the medical school is based. There is the first recall come from the GNC 1993, and that was of Tomorrow Doctors. That report published 1993, and the General Medical Council saying that the primary aim of the undergraduate medical course is to produce doctors with attitude toward medicine and learning which would fit them to their future professional career and self-directed lifelong learner. That was the first report for recall. And thus the medical curriculum should include courses that emphasize compassion, communication skills, appropriate behavior, and allow for independent learning. And the GMC identified two major reforms. The first one is that reduction of the factual overload. So many didactic hours that was we learned previously, so many hours have to be reduced. And the second thing is that promotion of the self-education, critical thinking, and evaluation of scientific evidence. The content of the curriculum should be defined and limited, while the teaching learning process should be changed to more active style, more student-centered. And many of the reforms should also target at making the basic science more relevant to the clinical medicine or years in the future. A second recall comes from USA by the famous report by Johnson Wood report. That report also urged more integration between the preclinical years and the clinical years. And if we can imagine the story like that, the Flexnerian system, we have the basic medical sciences, first 2 to 3 years, and then started some clinical experience from year 3, and then to clinical practice. While the new models come is that since at the start of the basic medical sciences, we have some clinical experience, early clinical exposure, and then in the middle, we have some clinical practice to be involved in the early years of medical schools, and then some of the basic data relevant to the to the clinical practice have to be maintained till the end. And this sort of integration was the more suggested model for the modernized medical education. The second recommendation is that to incorporate social and behavioral sciences to the curriculum, as well as familiarity with the topics would prepare the patients for health promotion and disease prevention as well. The third recommendation is that usually we trained our medical students at tertiary hospitals, while we have to extend their training to match the real life at primary healthcare centers, at mobiles, clinic, and etc. Because once the medical student will be graduated, will serve in these areas. And such a training will allow the student to see patient in different settings, and this is very important, and they understand the role and the need for the primary care. The fourth recommendation is about assessment, which is a very important because assessment drives learning. And assessment, it should be integrated one rather than separated one, because the patient come to you as a doctor, he is one unit, he is integrated. So I have to deal with him as integrated rather than disintegrated like we are teaching our student in the old system. The methods of the assessment also can improve the student learning, and therefore emphasis on active student-centered learning evaluating method should also be congruent with the goals. And this will be addressed in the future modules in the future. The other issue is that the recommendation is the creation of a body at the medical school. That body, which is the medical education unit, that will serve many duties. I will touch it within minutes about these duties. So the best curriculum is the one that produces a graduate who match the mission statement of the medical school. Now, what would be the best curriculum for the 21st century? This question is difficult to answer, but probably it will promote health of all people. They will be aware of the quality of the health of all people, aware of quality, equity of healthcare, deliver health services in a human and cost-effective manner, and to carry out this learning independently throughout his professional life, and to have high moral and ethical standard. This is a very important criteria for the new physician to be or graduate from medical schools. Health promotion, health equity, human and cost-effective health services, lifelong learner, self-learning, and then high moral and medical ethics to be trained in these medical students. In order to achieve all these goals, we have a certain body to manage this issue. And one of the innovation or most evident and increasingly widespread innovation in their introduction is the introduction of the problem-based learning. And that was invented at McMaster University 1969. The other invention was using standardized patients in learning, teaching, as well as in assessment. And the other thing is that using ambulatory setting, primary healthcare for training. That was a new development in medical education, as well as using skill labs, using simulation lab for training. That was advancement and changes in the medical education program throughout the years. Now we have, as if we have two kinds of curriculum. The old curriculum was highly teacher-centered, lecture-based, and discipline-oriented, while the new curriculum has become more student-centered, integrated, interactive, and faculty-directed. Faculty-directed. The new curriculum was integrated, the content was reduced, certain specialty modules were inserted within the curriculum, 20% to be problem-based to improve critical thinking and problem solving, more community-based training, and there must be a central curricular committee that have certain duties. It is usually chaired by the vice dean rather than the department, and a medical education unit have to be set in the medical school. And therefore, we can now recognize what are the roles of the medical education unit. Most medical schools who are serious about medical education have established a medical education unit in their institution. And the medical education unit, one of main role is that faculty development. The other role is that training medical students in group dynamic and small group learning activity, as well as problem-based learning. And the medical education unit helps in the development and monitoring of the curriculum. These medical education unit, they can act as a think tank for the institution, for the academic institution, which is the medical school, and participation in the activities of the medical education unit is a useful way for the keen basic scientist or clinical staff to contribute positively to medical education in their own medical school. And I recall from our modernization at Baghdad medical schools, there was 240 faculty members, some of them basic and some of them clinical. Because they are busy all the time, even no one or some of them doesn't know others, even they are working in the same institution. When we create the medical education unit, and when we start to change the curriculum, and we have collaborative work and working together, so much good relations were created between departments, and they work together in planning for the curriculum and in assessment and in monitoring evaluation. Thank you very much for your listening, and I hope I deliver some messages through my presentations about the history of medical education. ready to answer any question or any comment from anyone. Omnia?
Thank you so much, Dr. Hilal, for the insightful presentation. I'm waiting for the questions of the participants. Please, if you have any question, post them in the chat, or you can raise your hand and unmute yourself and ask the doctor directly.
I have one comment is that frequently, Mumtaz, when we started modernizing our curriculum at Baghdad Medical School, and there are now 10 medical schools change their curriculum. The big question is that why you are doing that? We are graduated from the past old Flexnerian style curriculum, and we are very good. We are leaders now. Why you are changing? Do you have any proof that the new curriculum is better than the old one? And frequently I be asked this question, give me the evidence that your new system is better than the old one. How do you comment on that, Mumtaz?
It's hard, isn't it? Because nobody likes change. But I think you started your presentation by saying that change is can be a positive thing, and it's changing to the societal and the changing needs and expectations. And I think things have changed, haven't they, and moved forwards, and expectations of patients have changed. The society is different and what we do is different. And there is more and more evidence of patient-centered care improving, kind of patient-centered care training, improving patient care. So I think there's more evidence now. And I think that is what I would feed back to the stakeholders to say, this is the way forwards. And there's much greater evidence. Whereas years ago, the evidence base wasn't as strong. But now I think patient-centered, empathic doctors, kind of all those things are well recognized as positive things. So it's continuing to have those conversations and then demonstrating the evidence that we have now to the stakeholders to hopefully drive the positive change.
Also, the second question, Mumtaz, I am the speaker and I ask questions too much.
That's okay.
Mumtaz, do you aware any UK medical school having the old Flexnerian style till now, or all have been changed?
All changed, because I think
no single medical school in UK still following the old Flexnerian style of curriculum. Am I right?
Yeah, not that I'm aware of, because I've gone to Medical Schools Council, kind of that's our governing body, like the GMCs for postgraduate and undergraduate training. The Medical Schools Council oversees the curricula and things, and it's much more of an integrated learning kind of pathway. And some have much more sort of emphasis on that, even more so around, kind of integration really early from the first year, and much more GP hospital-based, kind of learning as well. But not that I'm aware of. I might be wrong, but from the meetings and things I've attended from the wider groups, I've not heard that they adopt the older model now.
Thank you. Omnia, who raised his hand?
Yes, we have a question from Dr. Mustafa Ismail. Dr. Mustafa, please unmute yourself.
Thank you for your presentation, Dr. Hilal, Dr. Mumtaz. Regarding, there's some objection, like we hear, like we are from University of Baghdad Medical School, that, for example, regarding the new curriculum, that for example, they give that Oxford still with the old Oxford University still with the old curriculum, like the Flexnerian that you talked about, and they stick to this argument against the new curriculum. So I check now the University of Oxford and the Wikipedia, they say it's still on the old, like preclinical 3 years and 4, and the clinical in the last 2 years or 3 years. So is this a good argument? Like, is it a good and enough argument against the new curriculum, or what do you think about that? Thank you.
So just to say, if I may, Hilal, to begin with, that you have many medical schools who will have the preclinical and clinical years. I think that's, kind of fair, but it's how the curriculum is within that. So within that curriculum, you will have not just the basic science clinical practice bit that Hilal mentioned was part of the Flexnerian approach. You would have the much more integrated learning, the value-based learning, the wider ethics communication, and all those things across. And then how you both design the curriculum and assess the curriculum has changed for everyone. So although places like Oxford, Cambridge, Imperial will say some aspects of it is kind of traditional, even in Manchester, you still have preclinical, clinical years as described, but what happens in those is very different. So within the first year, you will be attached to a GP practice. You will have sessions in the hospital and things, which is not what I had. Although it was preclinical, clinical, that was 300 people in a lecture theatre for most part of the week, where you're just being taught and told, and a few tutorials. So I think, you know, although they can make that argument, you would say that interrogate and find out more, because it isn't followed in that pure traditional sense. There has been change, and that wouldn't be accepted now as far as the outcome-based learning now. That old method would not be fit for purpose, I don't think. I hope that helps, Hilal. Sorry, I didn't mean to interrupt.
Yeah, no, that's quite, Mustafa, I faced this question in person. You know, I was one of the team that we changed Baghdad curriculum, and we faced such an argument. But exactly as Mumsal said, it is the structure outside structure looks preclinical and then clinical. But if you go inside, and you can see the module inside, you can see there's integration. Inside the module integration, there is early clinical exposure. There are core clinical problems. There are everything professional, medical ethics, etc., etc. Only the outer frame is saying that's preclinical and clinical, and that's okay. When we said about clinical as or preclinical, as Mumtaz said, it is the old one. It is that we studied it completely basic sciences in the first 3 years and completely clinical sciences in the last 3 years of medical schools. And you can see so many medical students and myself, I'm asking myself why I have learning and spending a lot of hours and times in studying things I am not going to use in the future. And therefore, any basic science have to be linked to a clinical problem. And there's a very nice example I always heard from Professor Nigel Bax when I was with him delivering workshop, is that he usually said, please do your basic sciences in a clinical encounter so the student can realize the importance of this. And usually he said, as if a woman with her husband come to you and saying, my husband is passing urine too much, his urine smell becomes very similar to the nail polish, and he lost weight. What do you think this patient has? And what test you are going to do? And then he will go to the biochemistry through this clinical scenario. This is the importance, Mustafa. And I think the argument at the end, as Mumtaz said, since it is a competency based, at the end, there must be changes toward that. Do you have any question, other question, Omnia?
Nothing yet, Doctor. We're waiting for the questions of the participants.
Okay.
Yes, Dr.
Seems to
Hassan
be either my talk was very boring, doesn't stimulate anyone
no,
to ask
Dr.
questions, or my audience was sleepy.
You shared that slide, so they fell asleep.
Dr.
Okay.
Hassan has a question now.
Okay, Hassan, please.
Okay, thank you very much, Dr. Hilal. Actually, this is not a question, this is just a remark. So, apart from the students, I think more focus should also be placed on practicing physicians, because right now we have many physicians who still use outdated information and practices. So recertification is definitely missing in Iraq, and I think it's one of the causes of the lacking of medical excellence in Iraq. Thank you.
Thank you very much. We are missing many items, dear Hassan, and probably you are the seeds that will fix all these missings in the future. We hope that. We hope that. Any other addition or?
Okay, Dr. Sahar Abdul Rasul have a comment. Please, Dr. Sahar, go ahead.
Good evening to everyone, and thank you for the lovely presentations. I just want to say that in South Africa, at the University of at the University of Cape Town, which is one of the oldest university in Cape Town, it has adopted the problem-based learning 20 years ago. And that's on 2002, since I arrived in South Africa. I think one of the arguments that goes along with the new system or the problem-based learning is that it caters for more higher cognitive functions of the brain, if I am allowed to say that. So it's less rote learning and more integration. It encourages the student to use his higher mental functions. The design in itself is very supportive and very conducive for thinking. Thank you.
Thank you very much. Thank you. Thank you, Sahar. Okay, any other things, Umnia?
Nothing yet.
Brilliant. We are just on time. Brilliant. So at the end, if there is no comment, I should thank Mumtaz very much. I should thank all the attendees, my lovely team working with me, Omnia, Bishara, and Rami. They are the heroes of behind the scene working, as well as Mustafa Ismail and Mustafa Abbas working at the other course. This is not my course. The research course is not mine. And they are big heroes, really doing great job. And you can see that, Mumtaz. We tomorrow, inshallah, the next session of the module 1, it runs at the same time. And we hope that we may give some useful data to you to stimulate your thinking and to stimulate your action in the future. There are assignments. I send an assignment. I want to complete it and return it back to me, please. And I think Mumtaz didn't send any assignment because it was introductory session. Thank you very much. Thank you for all audience, and see you tomorrow, inshallah.
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 Nice to see everyone. Thank you, Hilal. Thank you,
Thank you
everyone.
very much. Thank you.
Thank you so much.
Thank you, Omnia.
Thank you.